Dr. Warren, it's 5:30. I say we get started.
We're good to go.
Well, good evening, everyone, and thank you for joining us for this special town hall hosted by the County of San Diego's Health and Human Service Agency and the San Diego Voice and Viewpoint. My name is Nick Mascione. I'm the agency director for Health and Human Services, and I'm joined this evening by my co-host and dear friend, Dr. John Warren, publisher of Voice and Viewpoint. I want to start by thanking Dr. Warren for this opportunity to have a conversation with the community about behavioral health services. Now, this town hall is part of a series to address important issues that directly impact you, the community. Last month, in fact, Voice and Viewpoint was very gracious enough to host a conversation about the county's child welfare services. And this evening, we have a brief presentation on the county's efforts to address behavioral health issues. But we're not just here to share what we're doing, very importantly. We want to hear from you, your questions, your feedback and suggestions. We'll be using the question and answer function at the bottom of your screen where you could submit your questions and comments. And we're going to spend a majority of the time actually addressing those. We also have interpretation services available in Spanish if you need it. And you can select that option also at the bottom of your screen. We know that behavioral health services is more important than ever. Over the past several years, the county has taken a hard look at our behavioral health system, both its failures and successes, and we have still a long way to go. There's so many organizations, though, that are providing critical services, and the county is just one piece. To everyone who works with our community partners, a sincere thanks. We've taken huge steps together to make our system work better for the people who need it most, with a greater emphasis on prevention and care and health equity, opposed to just responding to crises. We also have some exciting initiatives underway, including greater supports for our youth, which our behavioral health director, Dr. Luke Bergman, will talk about momentarily. We also have, we still know that there's gaps, though, and we're working on those. And I think we'll illuminate some of that in tonight's conversation. We're certainly clearly focused on equity in our work and aiming to better serve the needs of our communities, particularly our communities of color and communities historically underserved in our county in many ways. Now, this is an important conversation, and we want to thank you for taking time to being with us this evening. And again, I want to appreciate being invited here tonight and look forward to hearing from you. And with that, I'd like to turn it over to Dr. John Warren.
Well, Mr. Mascione, I want to thank you so much, your team, your staff, and all of the people who are here. Some people don't know that this is a continuation of a relationship that's existed for over a decade. And the Voice and Viewpoint now in the 63rd year is about advocacy, it's about service, and we have been on this journey for quite some time. So we know we have a lot of issues, especially in terms of behavioral health. I believe it was back in August of this year earlier with one of our colleagues that we did a session that specifically talked about the problems with our children in school and the shortages that we have and what we need to do. So what the paper wants to do is keep people aware that we are conscious and addressing the problem, and we're not just looking for a crisis to report. And so I thank each and every one of you for the work that you do, the extra time that you put in like tonight. And this is going to be a ripple effect. And I thank you for being a part of it.
Thank you, Dr. Warren. Appreciate you. Now it's my pleasure to introduce the county's behavioral health services director, Dr. Luke Bergman. I won't say a lot about Luke. I could spend a lot of time talking about his many accomplishments, but I'll just say this. He leads this ongoing collaborative effort with justice partners, our hospitals, our grassroots organizations, community groups, all together to enhance and expand and improve the whole array of behavioral health programs through our region. He's demonstrated this in Detroit. Maybe he'll talk a little bit about this and his work. And he is very passionate about serving communities of color. Now, I will say that he has been with us now a number of years and has done pretty extraordinary work in moving and shifting a mindset from not just crises, as Dr. Warren pointed out, but how do we prevent the crises to even happen in the first place? And I know he'll touch on that in his comments. So let me pass it on now to Dr. Bergman, talk more about his background, introduce members of his team that's here tonight, and then the work that they're doing, and that will follow then with questions from you, the audience. Luke?
Thank you so much, Nick, and thank you, Dr. Warren, for the opportunity to spend some time with you and the broader community tonight. This is really valuable. It's a valuable opportunity for us, and again, we're really grateful for you making this happen. I want to just note really quickly, I'm the Director of Behavioral Health Services at the county. I'm joined tonight by a few of my esteemed colleagues from the department, so I just want to call them out quickly. Cecily Thornton Stearns is an assistant director in the department and our chief program officer. Nadia Pravara is also an assistant director and our chief strategy and finance officer. And Kat Briggs leads our community engagement efforts here, and she's a recent and really wonderful addition to our department. And so I'm joined by those three. And we all, I think, will participate in some of the Q&A towards the end. I have a presentation. I'll aim to move through it pretty quickly. I want to start by saying that our approach to behavioral health is not about maintaining sort of what the system is right now. It begins with an acknowledgement that the system is, in some pretty deep ways, some pretty profound ways, broken. That the sort of basic structures that make behavioral health what it is need to change. The basic expectations that we all have of behavioral health need to change. And so we approach this work not just as like stewards of a system, but as activists. And we're bureaucrats, let me acknowledge that. But we approach this work as activists who aim to really deeply disrupt how things have been done, so that we elevate people's understandings of behavioral health and are able to really make a profound difference. My approach to that, I think, is informed by a couple of sort of past experiences or gigs that I'll reference really quickly, and then head into some slides that I'll go through. So before coming to San Diego County in this capacity, I actually spent much of my younger childhood in San Diego County. Before coming here to work in this capacity, I worked in Detroit, Michigan primarily, and then in New York City for a bit over the previous decade. And in Detroit, I actually did a couple of stints in Detroit, but my primary focus in that work was on working with folks in the heroin trade in inner city Detroit. Detroit, of course, is a famously challenging place, the most segregated major metropolitan city in the country, and dealing still with a long history of kind of post-industrial exodus from the city, disenfranchisement among people living there still, and the social consequences of that. The work that I did in Detroit, first with young people in the drug trade, and then later with a community of providers working on substance use recovery systems in particular, was really about culture and culture change. And I am still very influenced by that work and the approach to behavioral health that I take and that I think we take as a department. And that begins with a recognition that behavioral health is a cultural construct. Mental health means different things to different communities. And then if we want to make significant changes in behavioral health, the work isn't just about changing the proportions of services that are offered here and offered there. It is that, certainly, not changing the sort of technicalities of its relationship to healthcare mainstream. It's about culture change. It's a cultural change project that we're engaged in. And that really means like changing what mental health means. And of course, it means different things to different folks, different things to different communities. And so we have to take an approach to the culture work that we're doing by acknowledging that important fact. Mental illness means something very different in the Black community than it does in the Hispanic community, than it does in white communities throughout this county. So culture change is a deep part of what we do. The work that I did after I was in Detroit was mostly in mainstream healthcare. It was at the New York City public hospital system, which is this massive hospital system there. And most of what I was devoted to there was trying to integrate behavioral health into the rest of healthcare. What I sort of discovered when I started working there to oversee behavioral health is that it was all very, very siloed, very separate. And what was very clear is that if we want to, at the population level, improve people's behavioral health, it can't stand so far in the margins. Behavioral healthcare has to become a part of healthcare writ large. I want to turn to the slide deck that we have, if we can. I saw it flit up briefly. Can we go to the next slide, please? So Nick mentioned in his introduction that one of the things that we're really focusing on is shifting our emphasis from one oriented around crisis to one oriented around upstream prevention, continuous care. And what that is about is making changes to how services are provided, making changes to where it is that we make investments. But that is also a deeply cultural project. We have to stop thinking about behavioral health as necessarily an instance of crisis. And we got to think about behavioral health and what we can do to address people's behavioral health as normal, as just as normal as caring for diabetes, as just as normal as caring for a broken wrist. And if we're able to make that cultural shift, then a lot of the other sort of more technical, sometimes financial work that we need to do will follow much more easily. And so this is sort of like a framework that we present over and over again. Right now, we've got a system defined by crisis. People go to acute care at numbers that are absolutely much more than they need to because we don't have a system that works with people sufficiently upstream. We have not normalized behavioral health enough to make it as accessible as it needs to be to everyone to prevent crises. So we have huge numbers of people calling 911 in the midst of a behavioral health crisis instead of already getting care through healthcare. We want to flip what we see as an upside down pyramid right side up, build a foundation in preventive care, build a foundation in continuous care. And we see an opportunity to pretty massively reduce our investments in crisis services and to massively improve the experience of people with behavioral health. They won't be in frequent and recurring episodes of crisis. They will have continuous support and will live more stable lives. Their journeys into and through recovery will be better and happier ones. Can we go to the next slide? This effort to turn this upside down pyramid right side up is really rooted in kind of three big ideas. One is population health. We can't begin our work by thinking about the population of interest as already segmented from the rest of the world, from the rest of our community. We have to take a holistic approach. We have to look across all communities. We have to, I would say, not just respond to the demand that our system feels. We have to anticipate what the needs are. And in the world of behavioral health, needs can remain silent until the worst outcomes happen, right? People often do not seek behavioral health care because it is so stigmatized. And this, of course, varies community by community. But we have to take a population health rooted in data, driven by metrics that aren't just programmatic metrics. They are broad population health metrics so that we can see before people come and ask us for help, what's the need out there? What's driving the need? How is it that we can anticipate that and push resources that are preventive into addressing that before we see people in full-blown crises? And that has really accelerated those two efforts around population health approach and key metrics by what we call the AAA, which is this idea that there's a connection between the experience that people have in behavioral health care, the outcomes that we're able to get for people in behavioral health care, and the cost burden of providing behavioral health care. If we're able to do more work upstream, we are going to be able to reach many, many more people much more efficiently. We go to the next slide. This is a slide that shows some of what we've been up to over the last number of years. I've been in this job for about 4 years, and we have built an enormous amount in that time with the support of our Board of Supervisors, with the support of Director Machione and the Health and Human Services Agency. We've really leaned into establishing new service categories that we know are going to accelerate our effort to turn that upside down pyramid right side up. So one of the things we've known that we need to do is make a new system for crisis diversion. Too many people go into emergency departments and winding up in inpatient care. How can we stop the massive flow of people with behavioral health conditions into medical emergency departments and get them more specialized care? So we built two big things: a network of crisis stabilization units and a region-wide mobile crisis response team capacity. Those are represented in the orange flags that you see on this map. Again, regionally distributed, most accessible to all communities across the county. What we're already seeing is huge numbers of people diverted from emergency departments and diverted from inpatient stays in inpatient psychiatry, but rather connected to more community integrated levels of care. So crisis and diversionary services is a place where we've been making a lot of investments. What we call behavioral health hubs and care coordination, that's making sure that when we've got inpatient care, we've got step-down services connected to it, we've got data connected to it to help people connect to ongoing care. Long-term care, this is a hugely important body of work that's probably not gotten enough attention, frankly, but there are many, many people, thousands of people who will need some kind of ongoing support after hospitalization or instead of hospitalization. And we have had in the County of San Diego a really massive decrease over the last number of years in capacity for that kind of long-term residential care and support that you see in places like board care. We've lost about half of what we had that was accessible to people on Medicare. So we're making new commitments to reestablishing that capacity for long-term care in settings like board care, distributing it across the community and making sure that if people experience hospitalization, we are able to get them into a long-term care setting that's going to prevent rehospitalizations down the road. Next slide, please. I was talking before about the importance of population health data and the importance of being able to see into our community better than we've been able to, right? We've been primarily reactive in building the services that are our continuum. So one of the things that we've done is work with UCSD to build something called a Community Experience Partnership. And right now, a kind of primary nexus of the Community Experience Partnership is a website, communityexperiencepartnership.com. And what it provides to the whole community is a set of very easy to navigate dashboards that anyone across the county can access. So providers of services can access these, but any community member can access these as well. And to navigate through different portals that present different kinds of data so that our broad community understands what needs are. So that when there is interest in coalition building among our communities around needs, there is data accessible to them to help them make the arguments and to help us more broadly have conversations, transparent conversations about where we need to do work. So this is just an example of one of the images from the community experience partnership dashboard that we built that just shows housing burden for renters and highlights where it is that we sort of see that in most pronounced ways. Also accessible through this portal, though, are service data, and they can be broken down by demographics like age, gender, race and ethnicity, et cetera, et cetera. So this is sort of a foundation for a broader set of community engagement work that we're really highlighting. It's really important that our work be evidence-based, that it be responsive to what the literature says works best, but it's also really important that it grow out of conversations just like this one, Dr. Warren, that you've been generous enough to convene. And we feel like this kind of conversation can itself be made only more useful if we all have more access to this kind of information, to the sort of basic data that helps us understand where we need to make investments. So I wanted to highlight this. I think this may be the last slide that I was going to go through. Yeah. So that is very high level. There's, of course, as Nick was saying, lots and lots and lots that we could say, and I think we're excited to get into additional details depending on questions that people have.
Thank you, Luke. Great actual presentation you provided. And we have a number of folks from the community who have submitted by name questions. And I'll see if Fernanda has any others that they provided. But I have already a number that have been eager, again, who submitted these questions for you for this session. But before I turn to the participants' questions. Dr. Warren, is there anything you would like to ask Dr. Bergman, and then I can go into the submitted questions?
Well, I just want to make an observation. As he was talking about the cultural aspect, I was remembering, and I think Elizabeth, you were in on some of these, that we used to have these meetings back in the days of Harmonious Solutions and other entities where we were trying to do just what he mentioned. We were trying to culturally discuss issues. I think one of the problems that we have tonight, and we did e-blast to hundreds of people in terms of this program, a lot of people either are not aware that they have mental health crises, because the only time we get that in our schools is when we have a tragedy, and then we send a team of people in. But we don't really, we're still working with that whole team approach with the police and other law enforcement elements. Where we're only responding when the crisis is right there.
That's right.
So I think I'm concerned that we don't lose the ground that we initially covered, that we get back to those kind of sessions where we bring people together and sit around in that circle to talk. And I think now that the pandemic is over, we're going to be more successful probably with some of that in person than online. Just because of the nature of what we're dealing with. But I just want to thank you for laying the groundwork for all that you've done so far.
Yeah, of course. And I think you're right. With the pandemic subsiding, we do have opportunities to have, more frank conversations about these kinds of issues. I think this is wonderful. I do think we will benefit from more conversations that are in person. And so I look forward to those. I guess I would also say that that I think the pandemic, and I think we'll sort of feel this in retrospect. I mean, in retrospect, 10, 20 years from now, given what we know about the lagging, effects of trauma on mental health and wellness, we are going to see the impacts of trauma related to this pandemic decades into the future. We are going to see upticks in behavioral health need many, many years from now that we're really seated in the moment that we're in right now. And that's going to be a challenge. And we need to sort of, I think, stay vigilant about the importance of this work in light of that. At the same time, I think the pandemic has had a singular impact on making people aware of behavioral health as a thing that's as obvious, as intuitive as our physical health and wellness. I think people, and it's in the way, it's sort of on the airwaves now in a way that it wasn't before. People talk about how they're feeling.
Yes.
In a very different way than they did 2 and 3 years ago. It's at like an incalculable cost, right? We know that psychological distress increased by 200% in early data from the pandemic among adults. It's severe depression, it increased by 500% in early data that we saw reflecting what was going on in the pandemic. So an enormous cost that we still are only beginning to see. But it also, like, what we have is a moment right now, right? People understand that they have behavioral health in ways that they never did before. And it's a moment we have to, there are all kinds of, I think, catchy phrases about how crises are opportunities, right? Never let a, I don't know, Nick, you must know this phrase about never letting a crisis go wasted or something. But I think that's the situation that we're in, right? We have an opportunity to normalize the work that we do. So that, and I love the way you describe it, Dr. Warren. It's, what it has been is that people don't realize it's a thing until in some ways it's too late or at least way more in advance than it needs to be.
Well, you definitely perked the interest of the public, Luke, and I think you got a number of questions here, and some of them may be overlap, but I want to honor the individuals who took time to submit the questions, and I'll let you decipher how best to respond. So not in any rank order, just how these things have come in. First question is from Precious Jackson Hubbard, who wants to know more about what supports are there for schools and children.
That's so important, like especially in light of what we were just talking about. Like one thing I would note is that the County Behavioral Health Services Department, one of its biggest programs is a program called School Link, which makes accessible to people through school settings behavioral health services. And we have this kind of cited in over 400 schools across the the 42 districts that are within the county. An issue with School Link has been that it's available for people on Medi-Cal, and it hasn't been available for people on other commercial or private insurance. And it's been a challenging fit because schools don't think about people in like health insurance categories, right? So one of the things that we've really wanted to do, and again, with the pandemic is really key context, is create capacity that is not limited to particular insurance categories, and that in fact is really kind of broadens, really resets expectations around accessibility. So we've developed this program that we're in the process of implementing called Screening to Care, which is it's a universal screening program. And we are aiming eventually to have it across all districts across the county. And the idea is that we would screen, and we want to begin this work in middle schools. We'll screen all kids for behavioral health risk. Would not assess all kids, but screen all kids in a very brief manner. And what that will let us do is it will let us see really across a few categories, youngsters who are most at risk, who are kind of medium risk, and who are least at risk for behavioral health crisis. And then we are establishing engagement and care coordination services, again, across all districts, to make sure that we're connecting any child who presents with sufficient risk to kind of denote need with the appropriate care. And that may be through a service that's a county contracted service. It may be through a healthcare provider with whom they're already connected. Again, this isn't a payer class thing. It's not just for kids with a super high levels of risk. This is a universal population-wide approach. And it really represents a departure, I think, in how this issue is approached. County of San Diego, I would say, is way ahead of other counties in this respect. There aren't other counties doing this kind of work, and I'll report happily that it's caught a lot of interest from Health and Human Services leadership at the state level. So we see a lot of opportunity to sustain this work with support from the state in the future.
So, thank you, Dr. Bergman.
Nick,
Yeah,
if
Dr. Warren.
I really need to speak to this because Ms. Jackson Hubbard is a principal of middle school in this community. And that middle school has had some unique situations, Dr. Bergman, when we talk about culture. A couple of years ago, that school had over 70 students that were couch surfing. And so Black Men and Women United got involved. Mrs. Jackson herself is a product of San Diego Unified. And so it's more than a job to her. It's a lifestyle. And we got involved with that school. We created a pantry. We created supplies for the kids, take home things, personal items. But I've raised this question with the superintendent, and we need to get back because this issue has to be addressed in a even more immediate fashion than you're discussing. Because while your program sounds good, and I know she's in the second or third year of us trying to find relief. We've been in touch with housing to get homes for these families that were there. And so this brings the cultural thing right down to the road.
Yeah.
And she is not only walking the halls, but talking and being in hand in hand. And I did not talk to her before this evening in terms of this call because the Voice and Viewpoint was a supporter of Ms. Jackson when she was a student, Ms. Jackson Hubbard, when she was a student in San Diego Unified. So we've had this relationship a long time, but we've got to get more. As much as you're doing, I'm not going to let it end with us not going back to the superintendent and putting the pressure there because we've talked about this. There's supposed to be some additional dollars there, and I hope there's an effort to coordinate with you what the school system needs to be doing, because situations like Miss Jackson Hubbard School can't wait. We just can't. It's like being in a hotel and they're telling you to part in a mess while they renovate, but they're not giving you a discount for your stay.
Right.
Okay.
Right.
And so we need to really address that, Nick. I didn't want to take too much, but
No, I
I'm so
appreciate
glad that she bothered to call in.
And she's not alone. Sandra Eddy, E-A-D-Y, also added, related to that, will there be ample availability of resources for children? So I think that was another very related question, school age kids as well. So I want to make sure we honor Sandra's question there. Luke, another question was Manola Clark Manson, and like you to speak to the equity of care and the effective use of resources, including peer support resources.
Yeah. Well, so that, I think I hinted at how we're approaching that with reference to the community experience partnership, right? That what has traditionally happened in behavioral health, and this is true, it's just historically been true across the country, that the squeaky wheels have gotten the grease. And there really are, there are kind of multiple tiered systems that have addressed and that are available for people with behavioral health needs. If you're well resourced, if you can be a private payer, there are whole categories of care available to you, like critical categories of care that are absolutely not available to people who are on public insurance, or people, even in sort of like, kind of bronze plans from the exchange. And again, that's why it's so important for us that what we build is driven not by, who is demanding most loudly, but really what we see in, in the data, where there is need, where we see social determinants of health that we know are going to generate need over time. So the answer to Manola's question, I think, really begins with data. And this is, I will say, and I think my team would concur, it takes a frustratingly long time to build like the infrastructure to make data visible. And so we've been spending a long time on it. I think we're at a place right now where we have access in serviceable ways to data that is already informing how it is that we'll be making investments driven by equity. A piece of the community experience partnership is a behavioral health equity index, where we pull certain categories of data together to give different regions an equity score and equity value, and then that gives us an opportunity to prioritize where it is and how it is that we make investments. So some of it is just about like what's most urgent, where's their greatest need, where is it that we can work most upstream. That's important. I think part of what's probably informing Manola's question also is an interest in how is it that we're tailoring the work. And this, Dr. Warren, gets back, I think, to questions around culture. How is it that we're tailoring the work, shaping the work to meet the needs of culturally different folks across our county? That's also incredibly important. Behavioral health doesn't work as a cookie cutter project. It's gotta be relational. Can't be transactional. It really has to grow out of, frankly, like deep, real, authentic relationships. That's what makes it work. And part of what that means for us is that, addressing equity isn't just about citing, care capacity in this location or that location, or citing different categories of care in this location or that location. It's about the workforce itself. Who is it who's doing the work? And we're in a situation right now where we are in a full-fledged workforce crisis in behavioral health, right? We issued a report recently from the county. This was led by the chair of our board that estimates we've got around 17,000 people across the county who work in the behavioral health field. And by 2027, we need to add to that 17,000 an additional 18 to 19,000 people. We need to increase our behavioral health workforce by over 100% in the next few years, which is, it's a bit mind-boggling, but it's right. And that's how we have to think about the changes we want to make to behavioral health. The shifts have to be tectonic. We cannot chip away at the margins. But just talking about it in those numbers doesn't capture what's really important, because as we grow the numbers, we have to grow the diversity of our workforce, because it's only in creating that diversity that will establish capacity for that kind of relational care. And a key aspect of that is going to be peer support services, which I think is called out in Manola's question. There's recent certification at the state level that formalizes peer support work and allows for it to be reimbursed by the Medi-Cal system. I'll say California's been a little bit slow to the table with respect to that opportunity. Other states have established that kind of peer support reimbursement, in some cases a long time ago. But we're here now, and we have a great opportunity to, because of those new Medi-Cal reimbursements come into peer support workers, to really establish a new workforce, a workforce that, if we set the rates in the right way, can sustain livelihoods, can sustain families, and can create career trajectories, so people will stay in behavioral health over the long haul. But that population of folks has to reflect the diversity of our community. So we're, I think, Dr. Warren, it would be useful, if you haven't seen it, for you to see that workforce report. And for you to sort of share it with your, with your community, and sort of make it a part of I think, this, this presentation. it's important that we have a dialogue about what that report recommends. It certainly addresses diversity, but there's a huge amount of space for, I think, additional creative ideas to be brought forward about how it is that we shape a behavioral health workforce so it's most effectively able to meet our needs.
So Dr. Bergman, you have several other questions, and I'm just making sure we're going to try to squeeze as many of those in. Thank you for that response. And let me go to the next one. Billy Johnson is asking for an update on the governor's care court to address severe mental challenge from the streets that use majority of public emergency services in time.
Care court. Well, we could spend several hours just on care court. So I'll try to be brief. Care court is a new idea. It's not conservatorship. It doesn't create involuntary care, which is, I think, one of the things that people assume about it is that if one gets referred to care court, because it is going to be a court, that then they will be involuntarily subjected to care, like happens in cases of conservatorship. It is not meant to be that, at least in the statutory language. It's meant to be, it's a civil court, and which creates an order for care that technically isn't voluntary, but there will be pressure for people to engage in care in the context of, there will be court-driven pressure. People in care court will feel the weight of the justice system, compelling them to be connected to care, even though technically it's voluntary. It is meant for people who meet very specific diagnostic criteria, schizophrenia or psychotic spectrum disorders. So people who suffer with some kind of psychosis and for whom that's part of their diagnosis, people who are disconnected from reality. That's the most important and clear eligibility criteria. So it's not for everybody who's suffering with or anything like everybody who's suffering with a behavioral health condition. It's meant to focus more on people who are homeless or experiencing homelessness, but it doesn't have to. It doesn't have to. That isn't a cut and dried eligibility criteria. What the language in the bill says is you got to meet these diagnostic criteria, and a judge has to feel like it's very likely that you're going to wind up in worse shape than you are right now, and maybe even be in grave disability if you don't get connected to care. That's what it's meant to be. And Dr. Warren, it looks like you want to.
Yeah, I do, because there's some confusion. A lot of people don't understand how the conservatorship element works.
Yeah.
I didn't get it until when I first came here, and I was a law clerk for county council, and I got involved in some of that. But we have to help people understand the difference between the elements involved in conservatorship and what the court is trying to do in terms of the care court. And part of the care court approach was already addressed. You might remember several years ago, the California prison system went under receivership. And part of the reason for that was that there were people were not getting the care that they needed. And then that care was ordered, and many of those inmates were transferred to other facilities to have the kind of care that they needed. Now, if we're going to talk about San Diego, we lost some facilities that we had 25 years ago that were available to treat people. And if the court refers someone in that manner, we have to have the public understand the difference. And this is probably where you come in, because the court system won't do it. You got to have them understand the difference between a care court order in terms of a referral, say, to a behavioral facility. And in my clergy hat, I've dealt with some of that, where people were under those orders and some of the problems that were involved in doing that. So I appreciate Mr. Johnson's question, but we got to break it down a little bit more than we are, because we got to do something to educate people to the difference between that court, other than giving them what the proposition says, and the conservatorship And then where we are able to place people here, because I don't think we have those many facilities here in terms of bed space for folks at this point.
Well, if you know, if Care Court lived up to its full potential and compelled everybody who met criteria to get into treatment, our resources would be absolutely pressed. And it's worth noting that, you know, that this initiative doesn't come with substantial additional funding for behavioral health care.
Of course not.
And so it's going to be a serious taxation on the county. There are roles that the county needs to fulfill in assessing people and in connecting them to care that have nothing to do with what insurance they're on. So the population with which the county is going to be engaging all of a sudden is going to be much broader. I think the points you're making, I was just talking with my team about this, Dr. Warren, about communication about this are so important. Justice system involvement means very different things to different folks, right? I mean, talk about mental health meaning different things. Justice system involvement means very different things to different people across different communities. And that needs to be acknowledged. And I think the patterns of referrals across different communities, across different demographies really need to be tracked. Because I think there are all kinds of unintended patterns that we could see in how this rolls out. So I fully agree. Communication about this is going to be really important. It is different from conservatorship, but you know, the narrative about it from the beginning has been it's kind of been confusing.
That's because people didn't understand it. So that's it in a nutshell.
That's largely true. I think it's yeah, it's the reasons for the complicated narrative are are themselves probably multiple. But I think a lot of people feel like, well, Care Court's gonna, it's gonna solve the homelessness problem. It's just about homelessness. The statutory language makes clear it's not just about homelessness. I think people feel like Care Court's gonna, it's gonna make conservatorship unnecessary. That's also not at all the case. No. Care Court could increase the number of people on conservatorship, because if one fails to sort of pursue a treatment plan, they could wind up. And the language says they may, their case may be elevated to conservatorship. So we could see, but we're hearing both things. Right. I think the most important thing for the public to understand about Care Court is that we won't know exactly how it works until it's implemented. We won't know exactly how big it's going to be. We won't know the impacts of this kind of new sort of, presence of the justice system and people's decisions to engage in care. We're not going to really understand that until it's implemented. And I think it's important for people locally to know San Diego County is a round one pilot county for Care Court. So we're first at bat.
So Dr. Bergman, we got about 10 minutes left. You're a popular guy. You got so many more questions here. And so I want to let everyone know that Dr. Warren and I have made a commitment, as we did in our last session last month, that any question we don't get to that have been submitted, we will respond back to, and the responses, questions will be posted. Yep. So I don't want people to feel, well, I never got to my question. We will get that, because these are some really great questions. So I'm going to ask Dr. Bergman a little bit more of like rapid fire, and that's challenging because some of these questions are heavy coming, but I'm going to try to squeeze out as many more questions as we can. So one from Carol Wiggins, and I don't know if she's asking your insights and opinion on Senate Bill 464. Yeah. If you could, I don't even know Senate Bill 464.
I think Senate Bill 464 may refer to legislated efforts to reduce bias in healthcare. I think that's what that bill is about, with a real focus on maternal health, actually. Okay. And I mean, just what I would say really, rapidly, is any effort that we can make to reduce bias is an incredibly important effort. We don't have that kind of legislation, on the horizon that focuses on behavioral health specifically. what I would say is that there's been tons of legislation focused on equity and parity for behavioral health, right? Where we try to balance the scales between behavioral health and physical health. And to date, virtually none of it has worked. I think that's a really important thing for people to be aware of. We've been talking about legislative solutions to inequity in behavioral healthcare relative to other kinds of healthcare, and they haven't worked. And I'm happy to talk in future convenings about why, because it's sort of a complicated story. But legislation is an important opportunity, but it needs to be, I think, bulwarked by other kinds of efforts.
Okay, thank you for that. The next one came from, went through the three initials, KWE, who asks about mental health diagnoses taking place in urgent care facilities. So, and maybe this is implying to not just the CSUs that you have, but just more broadly and the public. So if you could speak.
Yeah. Well, what I'll say really quickly is that we have supported a few urgent care services, which are not 24/7. They're kind of long hour per day services for walk-in services that are less intense than the crisis stabilization units that we've built. The diagnoses that we see most frequently in crisis stabilization units are psychotic spectrum disorder diagnoses or schizophrenia. And crisis stabilization units are really effective spaces for dealing with psychosis. Psychosis is relatively quickly responsive to medication. And so if you couple medication, peer support, and behavioral therapeutic support, like crisis stabilization units do, you've got a really good recipe for pretty rapid stabilization. And we see that in crisis stabilization units. People with mood disorder, with major depression disorder or suicidality that's associated with depression, those can be more challenging presentations to stabilize very quickly and in a crisis stabilization unit setting. So one of the things that we're doing some thinking about is a category of service called peer respite or respite services, which can be a slightly longer stay service. And this is something I worked on when I was back in New York City. And it can be a very effective setting for dealing with people who are presenting with mood disorder. So CSUs primarily, psychotic spectrum, and then the respite work that we're just beginning to kind of think some about would be a more effective setting for dealing with mood disorders and suicidality.
Thank you. This next question was unanimous, did not provide any name. And the question is, how can communities and residents be involved in decision-making and give feedback to you?
There are lots of avenues, actually, and they're expanding enormously under the leadership of Kat Briggs, in particular, whom I mentioned before. I'll just quickly say, we have a behavioral health advisory board, and we meet monthly. And so there are always opportunities to come to participate in advisory, but so we're doing it virtually right now. Anybody can call in and make public comment, and I'm listening. So that's one sort of venue for speaking directly to me. We also support, as a department, I think the number is 6 distinct councils. And these are different from the advisory board meeting is what we call a Brown Act meeting. So it's very formal and parliamentary. The councils that we support, which include members from people from the service provision community, people with lived experience, family members, advocates, et cetera. Those are not Brown Act meetings. So they're a little bit more informal, a little bit more conversational. We've got a Children, Youth, and Families Council, we've got a Housing Council, we've got a Peer Council, we've got an Adult Council, an Older Adult Council. And actually, this is an area where we're thinking of growing our work. We're thinking of building additional councils that really sort of reflect the diversity of our communities, so that we're able to sustain conversations about how it is that behavioral health can be most responsive to specific community needs. So I would really encourage people to connect with councils. You can get information about those from our website, or we can connect, I'm sure, Dr. Warren, with you to make sure that as this gets released, it includes information about how to engage with our council.
I am going to read the next two questions because I want to honor the people who submitted it. We will get responses to it, but I'll give you a third question for you to respond to wrap up based on our time, Dr. Bergman. But one question that I'll have you and your team respond back to after this evening, and that is from Aaron Meyer, who asks, how many San Diego County residents are connected to assertive community treatment or ACT teams? Is there a behavioral health service centralized application process? How many people are currently on the waiting list? And how does the San Diego Agent Health Human Services determine number of ACT teams needed in the county? Lots of good questions in there. So we will get you and your team will get back to the doctor, to Mr. Meyer for that. The next question was, what are the priorities that behavioral health is hearing from communities across the county, and how are you responding? I think you spoke a lot about that, but we'll ask you to respond to that question. But I'm going to end on this other question from Carl Rainey, and it's actually befitting for this evening and next month's conversation around the homeless. But I do want you to respond to the question, and it is, what will you do today for the poor and the homeless in our town right now?
Well, I love the spirit of this question. I hear Dr. Warren's voice in this question a little bit. In Dr. Warren, what you had to say in light of the screening to care initiative that I was describing. I would like everybody listening to know that the Behavioral Health Services Department is out on the front lines every day. That we are not sort of sitting behind a bank of computer monitors, just kind of obsessed with data. We run case management services directly that are working on the ground with people who are experiencing homelessness every day. And the stories that we exchange with our county staff working in case management, working in outpatient clinic settings, and of course, working in our county's psych hospital, which is really ground zero, I would say, for the most serious needs in this community. Those exchanges are invariably compelling, moving, motivating. The work is, I cannot heap enough praise onto the workforce within behavioral health services that is doing that work every single day. Making a difference in people's lives every single day, and really every moment of every day. So, I think I want the broader community to be clear about that. And then I would just say, we feel an incredible sense of urgency about getting the work that we are imagining as future work onto the ground. And work really tirelessly as a team to make that happen. I think we have an enormous amount to learn, Dr. Warren, from the community of folks engaged with this kind of venue about where it is that we need to sort of rush into. And so I feel like this conversation right now is a thing we are doing today to, I think, advance that aim. And I'm appreciative of it. Dr. Warren, appreciative of you for creating it, and really looking forward to the continuation of it. What I feel is the inevitable continuation of this conversation in the near future. Thank you.
Thank you, Dr. Warren. I think as we close up on this, I'm sure that Dr. Warren will remind us all of words to deeds, which in fact you're closing strong on. I appreciate Luke, Dr. Bergman, you taking the time with your great team, with Cecily and Nadia and Kat, and just for the leadership and the passion and purpose, really helping our communities, particularly our communities who need it most. And it's evident just in your remarks and your actions. So a great amount of gratitude to you. I also want to acknowledge that we have Crystal Serving, our Central Regional Community Coordinator, who's been joining us for these series. Thank you, Crystal. And Elizabeth Pustos, our equity leader, champion in the Health and Human Service Agency, working with all of us and the communities. We also have a great support team on this, and I'd be remiss if I didn't mention also Sharon, Fernanda, and many others who've made this evening possible. But mostly, I want to thank all of you, everyone for tonight who participated, for the important questions, feedback, and engaging with us. As I mentioned at the start of this, this is the second town hall that the county and with Voice of Viewpoint is hosting. Next month on December 14th, we'll be back to talk about the county's Homeless Solutions Equitable Communities Departments and its important work in helping the homeless in our community, as well as talking about issues around, I call them newcomers, but our immigrants, our asylum seekers, and our refugees, and the work that we're doing there. So we hope you all will join us on December 14th. Bring your friends, bring your neighbors. We need to get the word out. And again, I want to thank Voice of Viewpoint for hosting. And of course, Dr. Warren, I would like to thank you immensely and also give you the last closing words before we wrap up.
Well, we want to thank you. I look at this as just the beginning. Just for the record, we did hundreds of e-blasts and notices throughout the community about tonight. And I'm glad that some of the questions that we got that you gave, Nick, came from some of those people who have been on the front line, very involved in what we're doing. I want to invite you to submit stories, profiles, the kinds of things that we can both print and put online to keep the matter in front of people. And Dr. Bergman, this is a part of how we change the culture, because right now people don't see anything other than in a crisis. And so we want to move beyond that. And if any of you individually have ideas that can be helpful, as long as you're not violating county protocol, I'm available to talk to you. I'm not here looking for stories. I get enough stories every day from everywhere else, but we're here looking for solutions because our motto is the people without a voice can't be heard. So we thank you this evening. We're going to rebroadcast. We're going to put this program up, and we're going to invite commentary, letter to the editors. We want this to be the beginning of an ongoing dialogue. And I thank you very much, everyone.
Thank you. Be safe. Have a great evening.
All right. Okay.